What I am going to cover here is the basic literature and what do we do in acute case scenario, what do we do in chronic case scenario, and what is the algorithm to treat. So the literature, I mean this is the systematic review where the most common injury is only axillary nerve, okay, and the injury, I mean the incidence is 5 to 55%, and 13% requires only operative treatment, that too at 3 months of if there is no functional recovery in the shoulder, and there is a window period of 3 to 6 months to decide depending upon the age of the patient, associated medical comorbidities and other factors. And these are many articles. They also say that when there is a shoulder dislocation, apart from an axillary nerve injury, we should also think about the cuff tear. So there is a diagnostic dilemma where the patient has a rotator cuff tear along with the axillary nerve injury. That requires a proper thorough assessment and then treatment. So with this literature, the acute case scenario, so this is a 29-year-old male, and the mode of injury was a bike accident, and he landed up here 15 hours post-injury with compartment syndrome and no distal pulsation with the fracture dislocation of this. So this was, and the extremity was completely wooden, very hard extremity as like a set compartment syndrome. So here this was the CT scan picture, and the CT angiography revealed no flow distal to the axillary artery. So of course on arrival, these were the vital parameter, and the dilemma was whether to salvage or disarticulate. Young patient, 15 hours post trauma, okay. So of course if you give the only option is shoulder disarticulation, but then if you have a backup of intensivist, a nephrologist and a physician and a good counseling session with the team of the doctors involved, that we can do amputation at any level. And if you tell them that we will attempt to salvage, but today if we salvage, tomorrow we may take him for disarticulation if his renal and pulmonary functions are compromised. So then we decided to salvage it. And so on exploration, what we actually found was completely torn, that was the deltoid muscle, axillary artery was completely injured, and the cord level of infraclavicular plexus injury. So clinically, of course, with this, this was the brachial artery, that what is seen here, and the brachial plexus or infraclavicular plexus of the cords were completely intact. So if the nerves are intact, vessel can be reconstructible by vein graft or a direct repair. But if at this level all three cords are transected 15 hours post injury, very difficult about commenting about the functional status of the limb. It will be just like a paperweight, okay. So because the nerve structures were intact and only the axillary artery was cut, so we involved our plastic surgeon colleague and a vascular surgeon, and he then did a proximal brachial artery thrombectomy. So these are the two ends of the axillary artery, and they did a vein graft reconstruction. So the axillary artery was reconstructed. That what we are seeing is a pulsation of the axillary artery. So both, and we 15 hours post surgery at arm level and forearm level we did a fasciotomy. So now this is the picture, and the limb survived without any systemic complication, and now at 4 months, so now he had adequate shoulder abduction that was painless, and the only thing he had is a radial nerve palsy, so which is definitely very easy to tackle. And we did a tendon transfer for radial nerve, and this is the result at 7.5 months post-op. And the functional status of the limb was also very adequate. He had of course 90 degree of stable shoulder. There was no drop arm sign. Elbow function was good, and wrist was neutral because the quality of pronator teres was also fibrotic. So he didn't have an active extension. But this is the functional status of the limb, which was you would have gone for a shoulder disarticulation. Message here, to have a proper backup plan. It is not a one-man job. It's a team effort, and patient has to be under constant monitoring of intensivist care. They require a forced alkaline diuresis We have to give lot of fluid to wash out myoglobins from the system. Otherwise, we have to keep a constant watch on the renal status and a pulmonary status. Sepsis, we are not worried in these patients, but keep in mind with the backup and young patients, salvage is possible. So that was the acute case, and now we will discuss a chronic case scenario. So where Dr. Dipit and myself, we managed the case. A 56-year-old gentleman, he had a shoulder dislocation due to bike accident, and in August 2020, it was reduced and then presented to us on, in February 21 with adequately restricted shoulder abduction and external rotation. So this was the no abduction possible here, and external rotation was just at the neutral. It was just not possible. And rest of the biceps function and a triceps function was adequately normal. So he had a classical shoulder dysfunction. So now here the diagnostic dilemma is whether we are treating only a cuff tear or an axillary nerve palsy also. So at 6 months, the regimen patch, sensory deficit, these are all very vague clinical examination to definitely diagnose. And definitely he had a deltoid vesting. So the EMG nerve conduction study, it showed no potential recorded in the the deltoid, the axillary innervated nerves, the muscles. And so at 6 months, these were the two diagnoses, like axillary nerve palsy as well as a rotator cuff tear. So now this is the dilemma, and the discussion is at 6 months, 56-year-old, little morbidly obese. If you do only a cuff repair and if the axillary nerve is not intact, he is not going to have adequate abduction. So this dilemma, we decided to do both at one sitting. So cuff repair, so Dr. Dipit did a cuff exploration, and so this was the massive cuff tear, okay, complete cuff tear. And he did a rotator cuff repair, and at 6 months, we don't anticipate a complete transaction of the nerve, but at 6 months the nerve should have recovered. So ideally in an acute scenario, or even at 5-6 months in a young patients, we should repair the axillary nerve. But honestly, that is not going to have any prediction of result at 6 months in a 56-year-old. So what we do, distal nerve transfer. So the radial nerve has got 3 branches. We take one branch and attach to the posterior part of the axillary nerve, because that is the motor nerve. And we did these two in one sitting, nerve transfers and a cuff repair. And this was the external rotation. There was no pain at all. So from neutral to he got 40 degrees of external rotation, and this was the abduction. So, and this was the forward flexion. So now we have to decide whether cuff has worked, cuff repair has worked, or distal nerve transfer has worked. But it has worked for the benefit of the patient. So again, the literature says that repair cuff at 3 months, wait for axillary nerve to recover at 6 months. If it doesn't recover, then you can do this transfer. But this patient presented to us at 6 months. So we had very limited option from the nerve point of view. Then we definitely get a clavicle fracture, and very rarely clavicle fracture will have a brachial plexus involvement. So this was the non-union of a clavicle fracture. Clinically, no shoulder abduction and a biceps function. But again, as this guy presented late, we did not explore the plexus, and we did not tackle the clavicle at all. So what we did is a nerve transfer. What we want is abduction of a shoulder. So we have a spinal accessory nerve which is paired. We attach to the suprascapular nerve, and in the arm level we have multifascicular, polyfascicular median and ulnar nerve. We take one fascicle and attach to the biceps branch. So rather than exploring plexus at longer in a chronic scene, if we do a distal nerve transfer, so they get an adequate abduction. These are all proved operations and with excellent success rate. So with this acute and chronic case scenario, what treatment algorithm that it can vary with depending upon the age of the patient, mode of trauma, associated injuries. But mostly if we see a shoulder fracture dislocation with a neurovascular injury, we have to find out whether there is a compartment syndrome or not. If there is a compartment syndrome and there is no distal pulse, get the CT angio done. If the CT angio and young fit patient and time frame is within our hand, like within 4 hours of injury if he has come, then reduce and fix the fracture. In the same sitting, if you feel it is not a cutaneous branch but at the cord level injury, you must explore the plexus and repair it, because that is the best chance to have the repair. And you have a full open injury, or you can have, this is the best chance to repair the plexus. But if there is a systemic involvement on arrival, like myoglobinuria or a high creat, patient has come late with systemic involvement, counsel about salvage versus amputation. And whenever you are talking about salvage in a, say dilemma, cases which has a dilemma, you should have a backup of a multidisciplinary team in the tertiary care center. And another, now if you get a shoulder fracture with only nerve injury and if there is no vessel injury, we can either, you can reduce, fix the fracture, wait for the nerve to recover, because the literature also says that only 13% people will require surgical intervention and 60% will recover on their own. But at 3 months, if they don't recover, then you should explore and repair the nerve and or transfer the, or do a distal nerve transfer. And in chronic cases, if there is a both cuff tear and a fracture, then you, the nerve injury, then you have to have a MRI and a direct communication with the neurologist to understand, because many times we just get a report of a brachial plexopathy and you find out whether what correlate clinically. But there are specific points in the EMG that we should see, like CMAP amplitude, sensory nerve action potential, and you analyze the report and find out whether the muscle that is paralyzed is getting re-innervation or not. If it is not getting re-innervation, the golden period is 6 months. After 6 months, then you have to go for salvage operations like a fusion or a tendon transfer or a muscle transfer. So this is the algorithm that usually we follow. And thank you so much. So the incidence is not very uncommon, but keep in mind. Thank you. Thank you.